Thanks for having me. So as a child neurologist, it makes sense that we don't really come into this profession with much information or knowledge on cannabis. It's not part of our normal curriculum, certainly not taught in medical school nor through residency. So where do we learn this? And it's very simple. As a pediatric neurologist, everything we learn that's decent usually comes from the moms that we see. So any of the good ideas that I've really come across have typically come from moms. I've seen some dads who've had ideas also, and I'll leave it at that. I'm a dad, so I can get away with that. So so my first experience here really came from a mom who was absolutely brilliant, who came to me with her son with autism, who was experiencing significant challenges with aggression. So he was, at that time, he was coming to me with reports from school. He was roughly 8 years old at that time, but he was coming to me with reports from school saying that they were making no progress. He was having somewhere between 50 to 300 aggressive episodes per day. Those would include things like biting, kicking, trying to run out of the classroom. The teachers had to wear Taekwondo pads just to protect themselves from the biting. And his plan, his individualized education plan, was not able to be followed. It was something that he simply could not meet any of the goals that were being set for him because the aggression overshadowed everything else that was happening. So we talked about the standard approaches. So at that time, it was a relatively recent article from the New England Journal showing benefit for risperidone for aggressive behaviors in autism. The mom knew the article inside out. She had read it, and she'd reviewed it, and she had her own criticisms, which were quite good, I have to say. So one of them was that it only enrolled 49 children in the treatment arm, and it only followed them over 8 weeks. And there really hadn't been, and there still aren't, very good long-term data for this. This issue of aggression in autism is something that is a major epidemic now. We're seeing, when you think of when the autism epidemic hit, it was something that really picked up 15 to 20 years ago. Now we're seeing 15 to 20-year-olds, and through adolescence, we're seeing that the issues in autism do change over time. So the young children that we're seeing, many times through adolescence, start to develop increased aggressive behaviors. This is more commonly seen in boys, but we do see it in girls as well. And a lot of the boys who I've seen with this had a history of regression, autistic regression, when they're about 2 years old. Many of them have a history of epilepsy as well. And when you look at what this does to families, to the individual, to the schools, it's a major challenge. It's not a minor thing at all. And so what happens with a lot of the kids, because I've seen many of these kids who've come from a background where they were put on antipsychotics, is the most common side effect that you may know is weight gain. So I can think of another patient that came to me who was at that time about 15, and he had gone up through the use of antipsychotics. He had gone from about 150 pounds to close to 300 pounds. So now he was not only aggressive, but he could have actually played in the NFL. Speaking, he could have been an offensive tackle himself. Not only was he aggressive, he was a 300-pound aggressive kid. He was about 6'4", 300 pounds, nonverbal. But he's like my lovable grizzly bear, though. He's a little like a grizzly bear. He'll give you a hug. He's the sweetest kid. He's got the greatest heart. But the aggressions, of course, when you're 300 pounds, and most of the workers in many of the schools that treat and deal with children with autism, many times you see mostly women at those schools, and not many of whom are 6'4", 300 pounds to match this guy. So it's frightening. A lot of the moms, so that patient's mother happened to weigh about 100 pounds. And when he became aggressive, he would hit her violently in the head. I have other moms who are covering their scars with makeup. And it's awful. I have moms who come to me who are afraid to bring their kids to the emergency room because they're afraid that their husbands are going to be suspected for abusing them, but it's their sons. So there's an epidemic now of women who are abused by their sons with autism. It isolates a family. It brings massive anxiety to the family, massive dysfunction, can often result in divorce. And then, of course, whenever that occurs, it's the mother who's left alone to care for these challenges. And when you think of as children transition towards adulthood, what are the placements for a 22-year-old violent or aggressive, nonverbal, obese boy? And there really are none that exist. So we have a major challenge now facing us with what happens in the adult world. So I have quite a bit of, I'm really a pediatric epileptologist by training. So I see and treat epilepsy. That's my specialty. But in doing so, I've sort of accumulated a large population of kids with autism and aggressive behaviors. And I had found that my own experience in the use of antipsychotics, antidepressants, was really limited. We still faced major challenges in terms of improving those core symptoms. And the most important thing to note is that the use of antipsychotics, although they had been shown in those trials to reduce the aggressive behaviors, they really did nothing for the core symptoms of autism. They didn't improve social relatedness or communication, which are huge parts of what we want to do. The other thing, too, is the increased appetite in many kids drives, because the child's hunger is driven, you actually sometimes paradoxically increase aggression because there are a lot of aggressive episodes driven towards food-seeking behaviors. So the refrigerator has to be chained sometimes. So the first mom, we worked together on this. This was sort of a journey. It was new to me. This was she came to me in about 2005 when this whole field of cannabis was very unknown to me. She presented many good ideas. We started first with Marinol as a treatment. It actually worked for a short time, but started to lose efficacy. And then we discussed whether she could find a grower, which she did. At that time, I was seeing her in Rhode Island at the time, which Rhode Island had medical legalization in 2006, 2007, in that range. But we still didn't have dispensaries that could work with children that were open. But over time, she's published, the mom has published on this. So she did a series for Slate magazine called Why I Give My 9-Year-Old Autistic Son Pot. And the series has now been in 4 parts. I recommend reading it. It's a great description of her journey, her personal journey with this. And she's very honest. It's not a complete fix, and that's not what she presents, but it's given her family and her life the ability towards something approaching normalization. They don't have to live in fear of those violent, aggressive outbursts every moment. Her son's actually performing much better in school, finally making progress, finally communicating, and it's really turned their lives around. So as part of the experience in treating patients with epilepsy, of course the epilepsy world really opened up very quickly after Sanjay Gupta's documentary. And the number of phone calls was tremendous. And actually, if you look at the rates of autism and epilepsy combined, there's very common overlap. So as many as 25% of children with autism will have epilepsy. Many kids, somewhere around 15% of all kids with epilepsy have an autism spectrum disorder, depending on the study you look at. So these two are shared in common, very commonly. You see 2 peaks in terms of when these present. So you have some patients who first present with epilepsy and later autism. That would be typical a typical example would be a child with infantile spasms or Dravet syndrome. That's very common to see. They have their seizures present at a very young age. And then you have some who present with epilepsy much later. So some who first had autism and later epilepsy. And there's a variety of different situations where that could occur. And so of the children with epilepsy who were medically refractory to treatment, which is, by the way, roughly 30% and so you're looking at the total epilepsy population in childhood is close to 1%, of which about 1/3 are medically refractory. It's kind of similar in autism, too. Many of the core symptoms we're trying to treat, the children are medically refractory. They just don't respond to the traditional treatments. So there's a lot of overlap in these conditions. So as I start to see more epilepsy patients, and I've now treated in the range of about 40 to 50 for epilepsy, within that population, I have more than a handful that have also had autism and had core symptoms of aggression as being one of the major components of what we were trying to treat. And of those, I compiled my data, which I had slides for you. But we were looking at roughly 80% or more that have seen some improvement in the behavioral aspects, not just in the seizures. So you're seeing a combined improvement. And this is a very important population, I think, to look at for many reasons. One is that the autism and epilepsy co-population, they share some underpinnings. So these are not two separate disorders. This is really, there's one single unifying diagnosis here, and you're seeing a variety of different diagnoses. And it becomes increasingly important to understand what the nature of that underlying diagnosis is and how each individual may respond. So examples, and there are many, but one of the most common examples that we look at would be Fragile X, which is really an issue of neurotransmitters, so mGluR3 receptor. And so in those cases, in Fragile X in particular, you see mouse models that have shown response in terms of some of the features of anxiety to cannabis as a treatment, to cannabidiol as a treatment. And so there may be specific therapies geared towards Fragile X in particular. For other types of conditions, you have mTOR conditions such as tuberous sclerosis or neurofibromatosis, another very common population that has both autism and epilepsy. And again, mTOR is listed on the pathways that we had seen earlier today. You have neuroimmunologic conditions, things like NMDA receptor encephalitis. Very rare condition, but there are many other types of autoantibodies that might contribute to both epilepsy and autism, things like antithyroid antibodies or anti-GAD antibodies. And again, looking at interestingly, anti-GAD antibodies, GAD is an important component of GABA synthesis, and anti-GAD antibodies are causative for type 1 diabetes, which we saw earlier today slides of improvement in. Not only that, but they can also lead to refractory epilepsy in some patients. And so as you go through these, of course, Dravet or SCN1A, there's a fair percentage of patients, so this would be more of a channelopathy condition, it's a fair percentage of patients in Dravet who also have autism. And it's going to become critically important to follow those developmental outcomes as many of them are treated for their epilepsy. So in terms of what's needed for this, so as we think about designing studies, it becomes critically important to look at development as one of the outcome measures. If you ask many of the parents that I see what is the single most important thing, if I could fix one thing, I'd say more than half would say it's not the seizure, it's the development that they'd want fixed. And so if we can improve development and seizures, that would really be revolutionary. Right now, the medications we have for seizures do nothing for development. And so to have anything that would actually improve both would really be a major change. So we have to follow development in all these studies. That's not an outcome that's currently being looked at, but it's an important one. The other thing that would be critically important to follow would be the importance of Eeg abnormalities, so what we call spike wave discharges that you see on EEG when you're not seeing seizures. The frequency of those spike waves and how that translates to developmental outcome and developmental improvement will be another important outcome measure to look at. We don't have enough data there, but I have, for my epilepsy population, I have a fair number where I've done before and after EEGs. And I'm in the process of counting spikes, which is not a very fun task to do. It's a bit laborious, but it's, I think, important to understand what are the effects of the EEG, not just the seizure counts. And so those outcome measures, coupled with better detailed understanding of the genetics and the underlying mechanisms of each child so we can better understand what works best for each child. And the thing I'd leave you with is that in autism, as well as epilepsy, each child is completely unique and is completely individual. And so think of snowflakes in this case. And I like to think of a butterfly as a great analogy because we hope to see that metamorphosis and see the child sort of take hold and grow wings. And so development, again, remains a critical piece, but each child is so unique, and so trying to determine that individualized medication for each child is something that has become far more complex, and we can't really do that without that understanding of their individual biological underpinnings. So that's the synopsis, and I did have some really great diagrams and slides and pictures, if you can believe me. So appreciate it.
We do have a couple minutes for some questions. So if you have a question, please step up to the microphone.
Hi, I'm Kirsten Velasco. I just want you to specify when you say you have results from, let's say, clinical trials or just single trials, you say CBD, and I think all of us want to know, is this a whole plant? Is it isolated 98%? Is it synthetic? Thank you.
Sure. So, okay, so what I'm referring to in my own patients who I've seen and treated, I've worked with the Slater Center in Rhode Island. So for the patients when I was practicing in Rhode Island, I'm still licensed there. We worked with the Compassion Center very closely. Primarily, many of the kids were, for epilepsy, many of the kids initially started with ACDC, usually in about a 20-to-1 ratio. A lot of them are now using a strain called Auto number 2, which is a little bit more like a 30 or 40-to-1 ratio of CBD to THC. Typically in epilepsy, we would start, I'd say the standard approach that we'd use would be to start them around a 20-to-1 ratio and increase them first to, we'd start around a quarter milligram per pound per day, do that for about a week or two, go to half, go to 3/4, and then to 1 milligram per pound per day. Usually as you get to about 1 milligram per pound per day, you start to see benefit. But we bring that up to somewhere in the 2 to 3 milligram per pound per day range for a lot of kids. It depends on the individual. And then as you get to those ranges, depending on the response, you may choose to add THC to their regimen. And so that's just a rule of thumb approach. And of course, then we're checking their levels of other anti-seizure meds. We're following EEG data and also carefully monitoring their seizure control. So I have, when I talk about data, I'm just talking about my own patients. I'm trying to compile what my own experience has been. These are the most refractory patients, and I don't want to understate the importance of this. A lot of kids, in Dravet syndrome, for example, Charlotte Dravet went back and looked at her original patients, and somewhere around 20% had died by the time they were an adult, a young adult. This is not insignificant. This is a serious, serious condition. So I don't want to downplay that, but I have seen better than 50% seizure reduction in the majority of these patients who have responded literally to nothing else that's ever come their way. Yeah.
Hi, good morning. As more of a layperson and listening to you talk about an epidemic in autism and aggression related with autism and its treatment, could you give me an understanding, though, of what you see as the reason or basis or causation of this epidemic?
Oh boy, that's like a whole other talk. That gets so complex. But I would just say, to simplify it, we are a product of our genetics and environment, and it would be silly not to explore both. And so our genetics is influenced by environment. Epigenetics is a major factor in development. So I think it would be foolish not to think that both factors play a major role for most kids. But as to the specific environmental causes, and we see a variety of genetic causes, that's complex enough. As to what environmental factors might be out there, that's a whole other talk.
We have time for one more. Sir?
Good morning. The title of your talk also references legal hurdles. I'm wondering if you could spend a moment or two explaining some of those hurdles that you had and how you surmounted them.
So that's sort of a whole other talk, but I'll get into that a little bit. So I decided to do something on autism instead because I actually think that's going to be a major growing area. But the legal challenges to either epilepsy or autism as a clinician are major because, first of all, I have a DEA license, and I can't practice or bill without my DEA license. The DEA is a federal agency. I'm specifically prohibited from recommending or prescribing any treatment that is Schedule I. And to do so, I could lose my license. Now, that means my language, even though I'm really or nobody here is from the DEA. Do we have any agents? I hope not. So before I say this, so I can't, ethically, how could I have a patient where what we're being asked to do from the state level is simply to say this patient has a qualifying diagnosis and that's it, and have no discussion further as to what specifically to try, what dose to do, how to introduce it, what to do with the other meds. I'm an expert in epilepsy. I've seen and treated a lot of kids with epilepsy. I kind of know how this goes in terms of how you introduce a med, how you taper a med, and how you follow levels. It would be really unfair for me to put that part of the management onto a compassion center or onto a caregiver. It doesn't make a lot of sense. I think we have to be directly involved in that process, but the state doesn't seem to think that's a good idea for some inexplicable reason. The second thing that's really important to me as a clinician is that the hospitals are not on board with this at all. Hospitals also have DEA regulations. They have a lot of federal regulations, a lot of federal funding. There's zero interest in the hospitals in dispensing or holding or having anything to do with any cannabis product, which means that we're forced to, you have a couple choices. You could have a patient with intractable epilepsy and suddenly take their meds away abruptly, which as an epileptologist I could say is not a good idea and really risks harming the patient. But that's what we're being asked to do. Or if I actually actively recommend that they use it in the hospital, I would get into quite a bit of trouble with administration. Or we could do a don't ask, don't tell policy, which is kind of where we've been. But don't ask, don't tell really is not I mean, that's a temporary measure. That's not going to play out very well over the long term. We need something better. And nurses and doctors really need to know what's going on with their patients, because this can influence our other decision making if we're not aware of exactly what's being given. So obviously we need this whole thing corrected, and a schedule change would be a huge help to clinicians like myself.
Thank you.
Thank you, Doc.